Good evening, colleagues. We're waiting for everyone to get in. There are still some people in the waiting room. Okay, colleagues, good evening and welcome once more to our weekly webinars hosted by Clinics Health Group. We're still having a few people in the waiting room, so as soon as most of them have joined us, we will start the webinar. But in the meantime, please note that these webinars are streamed live on YouTube, and you should have given us your full details when you registered during the course of this week, providing your full details, your name, surname, registration number, and also whether you're a medical practitioner or an allied health professional, or just one of the people who is in management within our groups or elsewhere. See, there's still a few more people. You still see a few people still joining in. I think they are stuck somewhere.
No, they joining in, Dr. Bila. You can start.
Okay, yeah, there are quite a number of people in the waiting room. But thank you to those who've joined us already. So welcome. As I said, my name is Raymond Bila. I work for Clinics Health Group as a group medical officer. And these webinars, we started hosting them in 2020 when we were in the lockdown during the COVID pandemic. And we are glad that most of you who joined us since then have always joined us this past 2.5 years or so. And we are glad to host you once more. And this evening we are privileged to host one of our own, one of our practitioners who's joining us from kaMaboza School of Health Sciences, with a different field altogether. First time that we do oral health in our webinars this year. So we are quite excited to have you, Dr. kaMaboza, to Week Clinics webinar. I'm trying to get my screen. I don't know what's going on today. Let me just minimize my screen. Just escape. Just a minute. I'm trying to make sure that I've got the right screen. Okay, sorry, just had some hiccups there. Okay, so thank you, colleagues. Sorry about that. Yeah, we're just reminding all colleagues who have logged in that please, when you log in, you are providing us with your full details, and so it is not necessary for you to put on the chat box your name and details, because once you register, we have all that information, so it will be uploaded and sent to the relevant regulator so that the CPD points can be allocated to you. And so this evening we are quite excited to have Dr. Funda kaMaboza, who has a Bachelor of Dental Surgery from a PhD, and also an Advanced Health Management Program for Foundation for Professional Development Business School, and also studied at Yale University. She completed the dental surgery PhD from the then Medunsa, or now the kaMaboza University of Health Sciences, and she's currently doing her Masters of Gender Studies at the University of KwaZulu-Natal. Dr. Babala has worked as a dental surgeon from 2002. Her community service call was at the Rural Benedictine Hospital in KwaNongoma, where she was the dentist and head of department. And after finishing her community service, she joined the King Edward VIII Maxillofacial and Oral Surgery Clinic. Her other interests are sex and sexual health. She is remembered by most through her involvement in sex and sexual education through different media and mentored by the giant Professor Elna McIntosh. And so it's a privilege and a pleasure this evening, Dr. kaMaboza, to welcome you. One breaking discussion because we've never dealt with oral health or dental health. So welcome to Clinics Health Group webinar. Thank you.
Good evening, and thank you very much. Before I get carried away, Dr. Bila, I think you are the first person that I need to pass my vote of thanks towards for having made me the first. Clearly, I have to try my level best to break a leg. I hope there's going to be a lot of orthopedic surgeons here to fix my leg once I break it. I'm looking forward to the discussion today. But as we start off, I think it becomes very important for me to first also, after I have thanked you, to thank the people that have been a link of making sure that we as oral health practitioners become part of these discussions. That's the kaMaboza Foundation, kaMaboza, with Dr. Vimba, and of course, Mr. Phil for being the conduit that has introduced us. Yeah. I am really looking forward to this conversation, and in that, today we get to then see, whilst oral medicine has always been separate, how do we integrate this and make sure that we comprehensively manage our patients? I also would like to thank you for being very patient with trying to get this presentation in order. Dr. Bila, together with everybody that has joined us in the team, together with the entire clinics team, today is the International Chest Day. So happy day to everyone that has joined us today. I hope the aim and the presentation goals, I'd like to thank you for having not given me any ground rules and having told me that this is the aim that you would like to achieve. So I then had given myself the right to say, I'm going to have my own aim and presentation goals, that by the end of this presentation, that I would have changed the attendees' mindset on how they view their own oral health personally. Whilst we are oral health practitioners, we realize that majority of us don't really get to look at ourselves and say, how do we care ourselves as health practitioners in the space of oral health? I am hoping that I would have punched holes on how the attendees carry their oral health as part of the comprehensive care in the daily business of their own health practitioners. Do we, as part of health practitioners in the health sciences space, make sure that if we're not oral health practitioners, that we comprehensively manage the patient? And if we have not done that, I hope we'll give you enough reason to say from today onwards, maybe we have to change how we've been thinking about comprehensively managing our patient and making sure that oral health is part of our day-to-day way of how we do things. As a third point, I'm also hoping that the attendees will have more questions than answers by the end of this session. In that way, Dr. Bila, your team and the work that they do as the last goal that I'm looking forward to is that we'll then have a continuous education going beyond the attendance of these sessions. I would really like to salute you as part of, before I start, to salute you and your team to having started these sessions, that they keep our practitioners during that difficult time sane, because it was very difficult time, and that educated and seeing how do we make sure that we manage all the other issues that we did not know of that had caught us off guard. The doctor ratio, patient ratio in South Africa has been one of the issues that have been contended by the South African government. In the recent accounts by the minister, Dr. Joe Phala, he revealed it that the country is at a ratio of 1:3,198 or 0.3 patients doctor ratio per patient, which means what we have been seeing is that majority of medical practitioners have been seeing at least a maximum, or have been expected to be seeing a ratio of about 1,000 patients, which is something that has not been seen in history of any of these countries. But we need to salute our doctors in that whilst the ratio looks the way it looks, there has been a great improvement on how our patients have been managed. On this one of ratio of doctors, we have seen that the ratio, though, of dentist to patient ratio is much higher than this. If we could move to the next slide, the ratio that we see of dentist and patient ratio is quite high, which also shows that at least there is about a ratio of about with the patients that we have in the country, or the population that we have in the country, which is 59.6 million, it means each dentist is allocated to a maximum of about 9,350 patients. Now, if you look at this ratio between the clinicians, your normal clinician, which is 1:1,000, and then 1:9,000, clearly it's a ratio that suggests that there is something else that we need to change the status quo in being able to transform how our oral health is taken care of, and how we can change the status quo. But this will be then translated by how we see the need, because in the previous time, and how sometimes our curriculums are being done, is that we have not comprehensively involved oral medicine as part of the patient management. And this can be judged and seen by how, for instance, if you walk into a clinician's room, if you are given the history taking a form, you'd realize that even though it would talk to the GIT, but it doesn't really talk directly to dental care. So how are we going to then, whilst in the midst of the problems that we are facing of 1:1,000 patients per medical doctor and 1:9,350 patients per dentist? Having said that, with what we have, according to the report of the HPCSA in 2018-2019, we've got about 6,374 dentists, which could have improved and changed to today between the past 3 years. And unfortunately, as I was looking through the archives, I could not see the recent report that was talking to how many dentists do we have now. But of course, dentists not being the oral health practitioners that we do have dental therapists, which according to the same report was telling to the fact that we've got about 1,257 dental therapists, and of course, about 740 oral hygienists. If we look at then the numbers that we have available, it takes us still to less than 10,000 oral health practitioners. And you'd realize that within the oral health practitioners, of course, we also do have specialists over and above the dentists, which also, according to the same report, was talking to the fact that we've got about 526 oral health practitioner specialists, still below 10,000. Now, if we're looking at the 10,000 oral health practitioners and looking at the population that we have in the country, which is about 59.5 million, how are we going to balance working with other health practitioners in making sure that we can take care of the dental care of the patient? And if you look at how oral health medicine or oral medicine is structured, you will realize that almost all the clinicians, one way or another, they have a role to play. And how do we then conceptualize in making sure that we are able to achieve this? As you can see also on the study that was done, or in the report by the World Health Organization, that the rate per dentist, not necessarily talking to all the health practitioners, is about 1:7.5 patients, which is, of course, a ratio that is very high, and easily it means there's a lot of patients that would then fall in the cracks and not being able to manage. This, unfortunately, then creates a burden of disease, where in a patient that could have been managed in a primary healthcare or a secondary healthcare ends up then with a condition or a disease condition that would have escalated to the third and the quaternary care level of care, which unfortunately then works together with what is the budget, or what are the financial implications of now having to manage a patient that you could have managed at a primary level of care and a secondary level of care. Now, the dental care, of course, in South Africa, it means, and it is suggestive of the fact that there is a shortage of dentists. There is, of course, a lot of studies that needs to be done in making sure that how do we then balance this equation? How do we utilize also the health professionals that we have in making sure that we are able to support dental care, or we are able to at least bridge the gap in making sure that we manage our patient in the first level of care, which is the primary and the secondary level of care, which will fall under your municipalities and provinces, and make sure that we don't escalate, because the minute you escalate your level of care from the secondary level of care, it also translates now to in investment which is higher than it would have been if we were able to cap the diseases. And unfortunately, as also in the previous slides, we would see that once we go to the tertiary level of care, as seen with the number of specialists that were recorded in the report by the HPCSA in the year 2018-2019, it is a very small number of clinicians. How do we then work together in making sure that we are able to cap the diseases? Not only that, members and attendees, there is another issue that we are then facing. There is an attrition in the dental therapist training in South Africa, and even the dental therapists that have been trained. Now, what does this translate to? As I was speaking, I'd said there's 3 levels that we mainly talk to, which is the dental surgeons or the dentists, there's the therapist, and then there's the oral hygienist. Of course, all of these oral health practitioners, they work hand in glove with the dental assistants, which is the primary person that keeps the core and the work getting done. These are also over and above these 3. We then have the specialists. But if you look at the work that is allocated between the 3 primary colleagues, which is your therapist, your oral hygienist, and the dentist, there is common work in which we can begin, we can do, which is mainly allocated to your primary level of care and secondary level of care. Now, we have seen that there has been an attrition on the training or the qualified dental therapists. There was a study that was done by Pumla Pamela Sondo et al., which is suggesting that the decrease has been so bad in such a way that it, even on a yearly to yearly basis, even before the students qualify, there has been students that are not necessarily disqualified from the profession or from the training because of the fact that they could not cope, but that just decide to drop off. So in the past 30 years, there was this study that was done, which was suggesting that about 40% to about 9% of the qualified therapists, or even before they qualify, they would have dropped off. Now, how do we then, with the attrition, already we are facing a limited number of the qualified practitioners that are supposed to be servicing this burden of disease, and now there is an attrition already. So that also is something that I'd like us to keep at the back of our mind as we go on to discuss and see what are these areas when we talk of human science that we need to look at, and how do we work together in making sure, with the attrition that is happening with the oral health practitioners and with the limited numbers that we have based on the population size that we have. There's a slide from the same study that is showing that the number of dental therapists that are leaving the profession. For instance, if you can see in 2019, which is one of the limited numbers that have left, before the number of dental profession who left the profession was 1. I am hoping that if there is a continuation of the study in the same way that we've seen that only 1 dental profession left the profession during that year, that this is ongoing, and that we are still able to retain some of the dental professions or dental therapist professions in the profession. This is very slow. The human resources in oral healthcare sciences, or in South Africa, on an update study that was done in 2018, there is a high prevalence of caries that could be prevented and treated by public sector. But of course, when we talk of treatment, and with some of the the policy imperatives that are coming. So it means there's going to be a change of mindset, that we're not only thinking now that the human resources that are allocated for the burden of diseases is only in the public sector. The infrastructure of the private health facilities needs to also be improved. So clearly this, whilst there is a human resource study on this, it also talks to the fact that it is very unfortunate that it is not the only resource that is creating or is having a negative impact on how the burden of disease when it comes to oral health can be managed. This also suggests that there is an infrastructure issue that is also contributing as one of the negative factors. Whilst we have the limited numbers, we have the numbers of the profession leaving the profession, we also have an additional issue in the oral health sector, which is also the availability of the infrastructure in the management of the patients. Okay, I'm unable to control this, so it then causes a lot of pauses. And if you look at this structure, this is what I was talking about, to say there is the 4 professional levels that are available, and all these professions, of course, they are working as a team. And you'll see that there is an increase in complexity, as I explained, to say on the primary and the level of secondary level of care, you have quite a number of personnel that is required, or the personnel that we have on the management, which is why it is ideal, or would be ideal, that as part of the planning and assistance of the comprehensive management of a patient, that we need to make sure that we are able to keep the level of care on the primary and the secondary level of care, because there we've got quite a number of clinicians that are available, your oral hygienist, your dental therapist, and your dentist. And of course, the study that we've talked to previously does talk to this slide. So I just thought on a slide format, which will just be a dashboard understanding of what we've been talking about, to say this is how the oral health practitioner data that we have in the country is sitting like. So I thought before we then go into today's discussion, it will be very important that I just give a comprehensive idea when we talk of oral health practitioners, to say this is where the country is sitting, but the need is much, much higher than the practitioners that we have. This next slide is just a slide that shows a white light being shined through a cone and then reflecting, which all of us do know. But today, what I would like us to look at is to say, now that we know the standing that we have of our oral health practitioners that we have in the country, and now we need to start shining the white light, and let's see what rays of light come out of it, and how all of us as oral health practitioners or as human health practitioners are we going to change the status quo. This then takes us to the next slide, which is the understanding of the African burden with the largest global increase on the oral diseases. Because whilst we all work as clinicians, sometimes because we are too busy and because we're categorized for work aligned purposes, we don't really get to understand what is happening in the other space. If you realize that this is a report by the World Health Organization only in March this year, oral health is an integral to general health and well-being. Is this how, as health practitioners, all of us see oral health? When we see a client, whilst we are going to zoom into our own area of specialization, do we start seeing the patients as general health and well-being part of a comprehensive management of a patient? Do we start looking and saying, what will be the effect of the oral health when I look at a patient? Yet it has been neglected. It is very unfortunate that due to the fact that there's other priorities that countries put in space, oral health has been one of those areas that has been deeply neglected. So yes, it has been neglected in the region, which is an African continent, often severe, causing severe and lasting consequences. And unfortunately, as I said earlier, if the patient is not treated in the primary and the second level of care, unfortunately, it then escalates to the tertiary and the quaternary level of care, which becomes very expensive. This is also the same observation that was presented by Dr. Matsidiso, who is the WHO Regional Director of Africa, to say Africa has got a burden of disease. Have we started seeing that oral health is one of those that we need to look at and that we need to incorporate as part of general health and that of well-being? Is this a practice that we have started looking at? And is this something that we, all of us as health professionals, started thinking on? So the WHO, after this observation of seeing that there's this burden of disease or of oral health that has not been looked at, then they started looking at global strategies to say, how do we assist Africa in making sure that it's able to look at oral health and adopt certain strategies in making sure that this burden of disease is looked at? Because they also realized that oral health has not been fully understood, and the impact of the oral health on our clients has not been fully recognized. So there was an undertaking to strengthen oral health information system. I have highlighted the oral health information system, because this takes us to a different level on how we have managed systems. And I am happy that we are part of a group that is clinics, which has got such good systems, because after I had started having a conversation with you, Dr. Bila, I started looking and saying, now I need to understand clinics. I need to understand what they stand for. Whilst they have invested at a very difficult time in making sure that clinicians are supported and clinicians know what they need to do during the COVID time, what else are they offering? And I've realized that you do have systems, and systems that are even talking to each other. Whilst, of course, in my research, I was not going to go deep into the systems, but I was just doing a desktop research of showing exactly how clinics work. Now, one of the landmark global strategies that we need to strengthen oral health information systems, in that a patient that was seen but in a rheumatoid arthritis clinic, when that patient is moved or that patient is channeled into a different system now of oral health sciences, those people need to be, or the clinicians need to be able to link together and say, okay, this patient is on this treatment, what could be the oral health implication on it? And when the patient is seen by a rheumatoid arthritis specialist, the specialist should be able to say, immediately, I have a responsibility. I have not only a legal responsibility, I have an ethical responsibility and an Ubuntu responsibility to make sure, whilst I have prescribed the patient a medication that could lead to a certain complication, but it is my responsibility to comprehensively link my clientele to an oral health practitioner, because I have now realized the impact that this would have if that is not done. So are we as health practitioners investing in understanding that we need to be part of an information system, and this information system is supposed to assist our clientele in how we are supposed to manage the patients? This includes also creating a new oral health data platform. Now, the new oral health data platform, because there is one thing that we have seen, which has caused a problem also according to research, that has led to oral health becoming this burden, is the fact that our clients also, in the same way that our health system has made oral health not a priority in the previous time, even our clientele don't prioritize oral health. And this is not just the clientele. I have seen also during the research for this project, I have realized also there was a very interesting study that was done by Harvard University, where they were doing a research on health practitioners, mainly medical doctors, and seeing whether are they taking care of their own oral health. And unfortunately, the results were very disappointing, because less than 50% of medical doctors in that study have been proven to say they were not taking good care of their own oral health. So this is also another way in which now we start looking at ourselves as one of the goals that I am hoping that we are going to achieve by the end of the day. Now, again, there is another report by WHO in 2019, where the organization says that there's millions suffering from tooth loss, oral cancer, and tooth decay, especially children. Now, the reason why I had picked up this slide is the fact that it talks to children. Once you talk about 41% of children 1 to 9 years old that have got untreated tooth decay, then you will see that as we progress, some of the complications that we're talking about with these children would be unfortunately suffering those. And how do we then assist in alleviating that? And about 25% of teenagers are suffering severe gum diseases. Now, there's two primary conditions that in the oral health that we work for, we on a daily basis have to manage, which is the caries on the disease, and we call this rotten teeth in layman's term, and also the disease of the gums. It is not expected in a normal world that children or teenagers would be suffering severe gum diseases. Now, again, I'm working towards saying, now we know we've got a shortage of clinicians. Now, how do we work together? Now we understand the burden of disease. We even have the World Health Organization coming and saying, Africa, you are sleeping in the job. Africa, how do you make sure that we prevent this from happening? Because if 41% of children are losing their teeth due to tooth decay that has not been managed, we are going to see as we go along in the presentation, what are these children going to suffer? Is this something that we can work together as practitioners in making sure that we can prevent from occurring? I hope I'll be able to prove it. So I said there's two main diseases that we see on a day-to-day basis in the country, which is the dental caries and periodontal disease. Dental caries being the carious teeth or the rotten teeth, and then the periodontal disease being the conditions that are mainly affecting the supporting tissues, and what we get to see on the outside being the gum diseases. So there was a dental caries study that was done in South Africa on adult population in Cape Town. The studied population presented with high burden of caries and edentulization, with very few restored teeth, and highlighted limited access to preventative and curative oral health disease health care. What I wanted to highlight on this slide is the fact that that limited number of oral health practitioners is then presenting, it can be seen in the studies to say indeed there is quite a high number of patients that are suffering that are unable to be assisted. And of course, if you look at this study that was done in Cape Town that I have picked up by Yusuf Chikle, it is not the only study that talks to this. There's quite a number of studies that are showing that indeed quite a number of patients in South Africa are suffering the dental caries. As part of the responses to some of the burden of disease, of course, South Africa had hit the call in making sure that they do come up with imperatives and strategies in making sure that we are able to support the cause. One of the causes being the fact that the National Oral Health Month, which is the month of September. We do see that there's quite a lot of work that is done during this month by the different institutions and also private sector. But we are calling on saying when we have months of this nature, it shouldn't be that it is only oral health practitioners that are participating, that would like to see even other practitioners being involved in some of these initiatives. Wherein, when you know you've got vulnerable patients, if it's something that cannot be done on a daily basis, then you then involve yourself in making sure that in this month, you also invite your oral health practitioners so that there is comprehensive care that is done for your patient and support. Okay, I have no idea why today my computer is so slow. I am just unable to control this PDF, and so it causes a lot of problems for me. Now we have looked at the two comprehensive areas that I wanted us to have a preamble on, which is one, the availability of the oral health practitioners that could support all the clientele with limited resources that we have. The second one being the understanding the burden of disease and the involvement of the South African government and the support that we have in making sure that this can be done. So this was mainly our preamble in understanding, so that when we go into saying now, how do we integrate the oral health care with human care or with the human science, then we have a better understanding of where and how at this present time oral health care is being in the map. If you were to map to say, this is where we stand, this is what the oral health practitioners are, and this is what the burden of disease is. Now, just to give a perspective, when we talk of oral health care, what are we talking about? Oral health is the state of the mouth, it is the teeth, and is the orofacial structures that enables individuals to perform essential functions such as eating, breathing, and speaking, and encompasses psychosocial dimensions such as self-confidence, self-well-being, and ability to socialize and work without pain, discomfort, and embarrassment. Now, at any given point in time, even sometimes when we discuss, we are having discussions with some of our fellow colleagues that are not necessarily oral health practitioners, you'd hear conversations or comments like, no, it's just about the teeth. Now, oral health is not just about the teeth, it is about everything around the orofacial structures and the entire face. So sometimes we have seen that mainly in clinics that might not have clinicians, a patient that comes with a swelling, instead of a patient being referred to an oral health practitioner, the patient will be referred to even an institution where there is no oral health practitioner. The reason why we are flagging this is so that everybody knows that most of the time, at about 80 to 90% of the swellings that you would see on experience in the facial region of a patient, most of those, if it is not trauma, they are oral or dental in nature. So when we refer our patients, it becomes very important that we don't waste time, because by the time they come, they've got swelling that are associated with some form of pathology. We need to be able to refer them to the correct or refer them accordingly. Now, over and above the fact that the mouth is not just for us to be able to chew food, what else is important, or what are the functions and the uses that we need to continuously keep at the back of our mind at any given point in time? The significance of the healthy mouth in general health and the well-being cannot be overemphasized. So if you do not have a healthy oral cavity, it means there is a lot of other matters, or there is a lot of other issues that might not be seen at any given point in time that will be related to the fact that you are not having a good oral health. In the same way, we are always saying that the eyes are the eyes to the soul, or they show the health of a human being. The oral health also is seen as a glimpse of what happens within the entire human health. To retain the dignity of a human being, the functions of the mouth should be at any given point in time carried without dignity. We have seen people that have got that don't have a very good oral health. Sometimes people that don't have their front teeth, that they would even struggle to eat certain food. We have seen these people sometimes even struggle to eat in public. So the minute the functions of a human being are carried with difficulty, and they are carried with the patient at least feeling embarrassed, it means there is something that us as oral health practitioners, we have not done wrong, we have not done correctly. So the call that I am bringing up as the first call is to say, when you see that the functions or the uses of the mouth have been compromised, what are you as a health practitioner doing? Have you referred that patient? Have you started having the conversation with the patient? And what other functions have been being unable to be carried by the patient because of the fact that they are unable to have they don't have a healthy oral cavity. Now, the functions of the oral cavity includes the following: a facial expression and communication. We have seen this quite a lot with the increase of everybody involved in, or majority of the people being involved in the social media, that the mouth carries a facial expression as part of how people carry themselves, or as an integral part of their image. Number two, the oral cavity also is very important for the formation of words. I mean, we've seen in certain circumstances where people are unable to pronounce certain words because they don't have teeth, or because they are wearing adjuncts like your false teeth, or dentures, as we call them in oral health spaces. Of course, another very and central important part that is affected by the oral cavity is the sexual lives and the sexual journeys of the people. How do we assist our clients? Do we even ask this question to say, how is your oral care affected your sexual health? This now doesn't speak to only the broader health practitioners, but even us as oral health practitioners, do we even ask them how this is affected, so that we are able to also channel the patients or refer the patients accordingly? As I had said earlier, that the oral cavity forms a very important and an integral part of the image of a human being. And also, of course, it is the start of the progress of digestion. There is a lot of research that does show that patients that don't have all the teeth, or patients that are wearing false teeth, or that are wearing other adjuncts in the mouth like your bridges, they struggle with digestion. And this, of course, will then have another impact. Do we, once we have given the patients the dentures, once we have given the patients the bridges, do we then refer them to dietitians to say, now, because of the fact that your mouth has changed, you might struggle with certain kind of foods. Maybe you need a dietitian to assist and advise on how, as you're getting along into this journey and getting used to utilizing your dentures, that you might need assistance in this space, in making sure that you maintain your health whilst you are getting into the journey of rehabilitation. So the disease of the mouth, on the other hand, may be indicative of systemic conditions. I have mentioned a few systemic conditions, and that might include some of the following: HIV. When HIV started to come up in the early 90s, some of the clinicians that are in the platform that were part of the research that were clinicians acting or working clinicians during the time, they would realize that one of the signs and symptoms that were picked up were patients having a condition in the mouth that was assisting in being able to refer the patients. Those were some of the areas where we've seen the hand in glove and comprehensive management of the patient that presented with Kaposi sarcoma that would be immediately referred for HIV management. So we do have these pockets of clinicians working together. But I am hoping that by the end of this discussion, we will see how important it is for us to integratively work together in making sure that we improve the management of our patients. So the systemic conditions were involving involve the HIV, oral cancer, as I've talked to Kaposi, and others, of course. Now, whilst we have seen some of these conditions, the challenges that the oral health space is facing, now human health is not only talking to the physical state of the patient, it is also talking to other spaces like the physical, psychological, and social well-being. So what I have done, which is the reason why I am bringing this slide on human health, is to say now, whilst we understand that the mouth is used for the specific things. Now, how do we link oral health to some of the chronic conditions, which are your physical conditions that are talking to the human health? We will at some point talk to the psychological aspect of human health, of oral health, and then the social well-being. And of course, we will then, as one of the last slides, talk to the oral health and how it affects the sexual journeys of our clients. What I then did as part of shining the light again on the prism and creating the different lights, I then went on research and I picked up on 11 conditions that have been taken to be part of the 11 chronic conditions that we find here in South Africa. Here I took on a study that was done by Affinity Healthcare, Affinity Healthcare being one of the service providers for health that also is presenting with a lot of researches. So here, in the 11 conditions, I am in a short space of time, not going to waste a lot of your time, just going to talk on a few of these conditions and how they link to oral health. Because my main aim is for us to be able to say, whilst we work in silos, it becomes very important that we need to create a comprehensive management of the patient. We need to create that system. We are at a time now where we are having artificial intelligence. We are having the point where we are now a bridge between the third and the fourth industrial revolution, wherein how do we then utilize the resources that we have available to us to support our patients. So the 11 conditions that I have identified based on the studies, and this is not the only studies. And if you realize, if you go back and look at the studies, you will realize that majority of these conditions, even though other studies will talk to 10, they are almost the same in no specific order. For instance, the stroke and heart diseases. If you look at the stroke and the heart diseases, there is a lot of research, even though it is not conclusive in specific areas, that is suggestive that patients that have got heart conditions, there is a definite link with them having oral health conditions. The specific oral health conditions, as I said, that there's two primary conditions that we deal with, especially in the primary and the secondary healthcare, which is the caries and the periodontal diseases. Here, they're mainly speaking to periodontal diseases. So there is a lot of research that is suggesting that there is a link of patients that are having oral health conditions, which is periodontal diseases, that will end up having any form of heart diseases. The understanding on some of these researches is the fact that whilst you have these oral bacteria that will be in the mouth, because this body functions as the system, some of these bacteria would then be able to be transported, of course, due to them the supply of the oxygenated blood and the retrieval of the carbonated blood back into the heart, and then they will have a direct impact. Of course, in this one, there is two schools of thought. There are those that are saying there is no direct link, but should there be work that is done in the oral cavity, it will definitely have an effect on the heart disease. I must say, in this specific area, there has been very good working relationships between the cardiologists and those that are working with patients that are mainly having heart diseases and the oral health practitioners. Because when you get referrals, the patients will be very clear to say, I have been referred. And also from the oral health practitioner's point of view, whenever you need to manage this patient, you'd have to deal directly with the physician that is treating the patient to say, I need to do this work. What kind of workout do we need to do in case there is a need? Otherwise, also, even in the oral health practitioners and teaching practices, there is a pre-prophylaxis that we need to give to these patients for management. So I must say there, big up to all the teams that are involved. And this only does not involve the physicians and all the health practitioners. This is a practice that we have done very well in making sure that we are able to manage our patients comprehensively without causing any possible complications. And now rheumatoid arthritis. This, I must say, also came as a surprise to me, wherein now I realized that there is a direct link between the rheumatoid arthritis patients and the patients that are having periodontal diseases. This, again, it's one of those that we need to look at. It is, in this case, not only the disease that would the disease or the condition, which is rheumatoid arthritis, that is directly linked to the oral health conditions that could deteriorate. But it is also the management or the treatment that is given to the patient that could then also have a direct link. The third condition being hypertension. Again, there is a direct link. Research does show that there is a direct link that is between a patient that is managed for hypertension and the burden of diseases that could directly link to the patient developing oral conditions. And once again, even here, from the oral health practitioner's point of view, when a patient is experiencing pain, especially dental pain, there has been a link. Research does show that there is a link on this patient because of the dental pain and most probably any form of pain that the patient would have an increased recording in their hypertension. The other chronic condition also that I have chosen that is forming part of the list of these conditions is HIV and AIDS. We have talked to this already when I was saying even in the early 90s, where there was a link that a patient that might have an immunocompromised or immunocompromised, not only HIV, that these patients could also unfortunately develop some form of oral health condition, mainly once again, periodontal diseases. Another condition being the epilepsy. Here, it's not just the link to the condition itself, but it is also when these patients are having those that most probably would present with seizures. We see that there might be some injury that might either include the tongue, and sometimes in cases of falling, the patient would present with broken teeth. We have seen also that here there's not a lot of working together, wherein a patient will only come and say, I was admitted in the hospital, and only after so many days, I went home, then I realized I had fractured teeth. So we have seen here that there is not a lot of good working relationship. And it's something that we should also at any given point in time, as we educate our patients on saying, now you've got this condition, these are some of the things that you need to look at. Also with epilepsy, some of the medication that is prescribed to patients that are living with epilepsy, you'll realize that they are also linked to periodontal diseases, wherein the patients will present with swollen gums and therefore leading to the gums being bleeding. The same thing with diabetes. Also, in the same way that the patient would have poor wound healing, we experience the same from oral health practitioners' point of view, but also it has been proven that patients that will live with uncontrolled diabetes, these patients would present with some form of an oral health condition or pathology, and mainly, once again, periodontitis. So I think it becomes very important that in our thinking, when a clinician or a health practitioner, being a nurse that has identified the patient, to say, now you've developed diabetes, so there is high chances for you to develop an oral health condition. So it's best that already that we refer you there so that we can start, as part of us taking care of you on this side, let's have the oral health practitioners of course take care of you so that we prevent that you having to take out teeth in the future. For cancer patients, once again, as I had said, this is one of those patients that we have seen quite a good correlation and working relationship between oncologists and oral health practitioners, and sometimes maxillofacial surgeons, depending on who is involved. That it has created one of those relationships that we need to work with. So it has been very clear that a patient that needs to go mainly for radiation in the head and neck area needs to be done a comprehensive oral health work, and this assists our patients so that in the future they don't have problems. And we have seen also the improvement in the communication and the teaching practices, because in the olden days that has been fully communicated. These patients would have been going through dental clearance, wherein, because we are going to have radiation in the specific area, we'd have to take out of all the teeth. But the communication, the communication and also the improvement of the level of care has been through research, and relationship between the units improved in making sure that the main thing is that we need to make sure that the patient is sitting with a healthy oral cavity before they go for the management. This has not create problems for radiation patients. We have seen also research has shown that even patients that are going for chemotherapy, mainly in the region and even outside the region, they will present with certain conditions that include your dry mouth and sometimes the development of dental caries. And so when these patients are there, so it becomes very important to say, because we know this is what you're going to go through, let's once already refer you to an oral health practitioner. And as I had said, there are instances where you find that you don't have a dentist, but you have a therapist or you have an oral hygienist. Some of this work that we do can cut across, and we can prevent any possible complications from occurring. Patients living with asthma, which is one of the conditions, the chronic conditions that have been identified as one of the conditions mainly here in South Africa. Asthmatic patients, while there's no direct link on an asthmatic patient themselves, on the disease itself or the condition itself that says the patient will have conditions. But because of the fact that these patients, they do suffer from the breathing practices, once in a while they find themselves breathing through the mouth. So this leads to a dry mouth, and in the process might lead to some of the diseases, oral health diseases occurring. And also some of the medication that is prescribed for asthma might have a negative effect or possible complication on the oral cavity. Obesity. Also, with obese patients, there's quite a number of schools of thought and researches that are suggesting that there might not be a direct link, but the link on obesity is mainly patients that are obese due to the fact that they are on incorrect diets. So the incorrect diet definitely might be a lot of sugar most of the time, and other sugar substitutes that might lead to the change on the flora inside the mouth, and therefore leading to the development of oral conditions. Alzheimer's, once again, this one was for me an eye-opener that there is research and massive research on Alzheimer's to say there is a link on patients that are presenting with Alzheimer's that this could have developed from an oral health condition. So if you look at all the 11 conditions, being number one, where we're talking about, which is why there's two of them. Number one started by saying stroke and heart conditions. So that's why it was clumped together and we ended up with number 10. So if you look at all these conditions, there is a definite link to oral health and oral conditions that could occur, either directly to the condition or the disease itself, or through the management of that condition. And how are we as oral health practitioners, after having seen the burden of diseases increasing with the most common conditions, and also followed by the fact that we've got limited human resources when it comes to oral health practitioners, how are we then assisting our patients in making sure that whilst we manage the conditions, we also are able to manage or prevent the disease or the burden of oral healthcare from occurring? Of course, as I had said earlier, we cannot then remove oral health and sexual life practices. We have seen the evolution of sex and sexual practices throughout the years. And of course, most probably it's an evolution that is continuing. In the olden days, chances are people, if you look at research, they would just involve on minimal use of the mouth, but for kissing purposes. But now we have seen that there's quite an increase of these practices, and they include your oral sex, that include even cunnilingus. It includes also the kissing of the penises. It also includes anal practices. How do we then, as practitioners, because whilst in the country we do have quite a few sex and sexual health practitioners, sexologists, be it clinical sexologists and educational sexologists, but the main people that are available are us generic or general health practitioners. Are we having these conversations with the patients to say now, for instance, even as oral health practitioners, we have seen, because of the changing of the lifestyle, that we see that the patients would go now and have oral sex, and that conditions that would naturally be seen only in genital areas are now seen in the mouth, and vice versa. And because we are oral health practitioners, are we in the front of having these discussions and educating our patients? And also, when we talk of sexual practices, of course, there will be a healthy sexual practice and unhealthy sexual practices. Do we as nursing staff, do we as physiotherapists, do we as medical doctors, during our normal a visit and taking of history, and also clinical evaluation. Look at the children mainly that could have been vindicated by people through oral sex, because as a clinician, we need to be able to say, I have done a comprehensive exam and I am convinced that should there have been anything wrong with the child, I have seen it, and then refer accordingly. So those are the 11 conditions plus sex and sexual lifestyle that are directly linked to oral health that are seen on a day-to-day basis by all of us as practitioners. Now, when are we then going to develop this link through the systems in making sure that we are able to work together and comprehensible are able to refer the patients accordingly? Now, of course, when we talk of health, human health, we've talked about now the physical conditions. Now, what is the psychosocial impact of oral health on our clientele, and not on our clientele, but on ourselves? As we've said, that the mouth or the oral cavity or the dental region forms part of the image. How does this affect the people? Whilst it has affected their lives in the different or sectoral areas that we talked about and the conditions, but what is the effect? Is it something that we also look at? Because there is one thing that is very central. We have seen that there is an increasing trend of our people going through mental conditions. And some of these mental conditions could have been caused by little things like your oral health. So there is oral health related quality of life. Do we, as part of the work that we do, zoom in the related quality of life associated to health, and mainly in the psychosocial impact, where the patient will have anxiety or the patient will be unhappy? Yes, whilst only in the dental space, the main patients that would see is patients that really have, there's what we refer to as a teeth not growing in line as expected, and those are the patients that we'll see. But you might find that there's a patient that has lost one teeth, there's a patient that has come to you that is unable to smile. So it means that patient's social life, especially in this day and age, has been affected. Research has shown that, and comprehensive research has shown that at least about 30% on one of the Harvard studies, about 30% of the patients that has presented in one hospital, they felt they were not treated with dignity because they were suffering from an oral health condition. These were patients that have missing teeth in front or patients that were wearing dentures. And in that study, the patients even also stated the fact that they would even struggle to get partners, or they would not be married because of the fact that they've got oral health. So the psychosocial impact of oral health is quite huge, and is it something that we look at as oral health practitioners? South Africa is utilizing huge budgets in general medical care. Unfortunately, there is no specific values that has been associated with the dental care. But if we are able to work together as SIN on the primary and the secondary health care and be able to identify the conditions, whilst you are managing the patient with diabetes, you make sure that they are referred directly to a dental health care. Whilst one is managing a patient with arthritis, they make sure that they are referred directly to a oral health practitioner. Whilst a dental practitioner is also managing a patient that is sitting in their chair. Because also there's one thing that has happened. There is a beautiful study that was done on patients that have got a periodontitis, that male patients that have shown to say there is a link between a dental practitioner's work or the dental condition and sexual dysfunction. When the patient is sitting and you are looking at their oral care, do you even find out, of course, in a professional manner without vindicating the patient, whether this has an effect on other spaces in sexual life, and referring the patient accordingly. So if we are able to do this, in no time we'll be able to curb the financial burden that this is placing, not only in private sector, but also also in public sector. And as seen, there is a research also that has shown to say majority of the patients during COVID, one of the things that they had to let go is a medical care a budget. And in this happening, it means those patients will then have to suffer. So when we don't refer patients accordingly, and when we don't work comprehensively, have we thought of the financial implications that come with this burden of disease that we might not be managing accordingly? We are almost at the end. Here, I have just picked up one or two history-taking charts, and I'd like to reassure my fellow colleagues that these ones were not taken from the South African charts. I mainly had to look for ones outside the country. And if you look at these history-taking charts, even though this specific one would talk about the gastrointestinal condition, but if a patient, which is one of the studies that has shown, when you ask a patient if they've got a gastrointestinal condition, the patient, they don't necessarily relate it to an oral health care problem. They will mainly be thinking about the fact that, do I have a running stool or a diarrhea, or am I having constipation? So this is just two charts that I've taken, or files that I've taken online, not necessarily South African, that are showing that we are not working comprehensively. We are still working in different clusters. And how do we then assist in making sure that when we look at the level conditions and other conditions and other aspects, how do we work together in making sure that we are able to improve and assist the oral health space, and not only the oral health space and practitioners, but our clientele, in making sure that we are able to work together and comprehensively manage the system, especially as we go into the automated systems and electronic systems, which are systems that are supposed to be talking to each other. Okay, I think we're in the last two slides. Now, the more questions that I have, because as I said, when I started off, I'm not going to be providing any responses, but mine is to provide more questions. And that when we start probing into these questions, we'll be better off in being able to take care of our patients. Are we managing our patients comprehensively? What is the ethical consideration when a patient has come to you and you know of the possible complications that could occur, and you know of a specific clientele that a colleague that could manage the patient, and you could co-manage the patient, and you have not managed the patient? And if there are those ethical considerations that we have not really thought of and we have not been practicing, what are the possibilities of the legal liabilities? And is this something that, as a health professional, or all of us in this space, are able to manage and be able to curb? If we have realized, or that we have been ethical enough in us not being able to comprehensively manage our patient, are we going to be able to bear the brunt of the legal liabilities? If we have looked at all this and you realize that you will not be able to, you have not done your part as a health practitioner, where is human nature and Ubuntu in all of this? And how are we supposed to change the status quo in making sure that we work together whilst we have limited resources and we have got limited numbers on specific areas, but we now know the link of how these things are linked together in comprehensively managing a patient? Ubuntu, where is Ubuntu? And also now coming back home on our self-care, because also the studies have shown that majority of the healthcare practitioners that are not necessarily oral health practitioners are not taking care of their own oral health. Is this something that now that we know the possible complications, or because we do know the complications, now that we have reminded each other of what the possible complications are we now going to change how we look at life? Are we going to be the tree of life that we had signed out to be as an ethical health practitioner in making sure that we're taking care of our patients comprehensively? That was a very big, long one. I'm sure Dr. Bila was looking and saying, when are you finishing, so that we have time for questions?
Thanks a lot, Dr. Babala. It was quite a good presentation. Quite a number of people are saying a great talk. It's a first for us. I think it was a good lecture on oral health and dental medicine. Quite a lot to learn, and I'm certain that I would love to hear more because there is a lot that we haven't had, on dental health or oral health in a long time. There's a question that was, I think I'll start with that one first. Dr. Mongo says, in the public sector, there are more patients than clinicians. For example, one dentist has 30 or more patients a day for extraction. Is that right? How many patients is a dentist supposed to see per session? We'll take each question one question at a time. Yeah, you're muted. You're still muted. If you can unmute yourself. You can't, Kamu, can you help? Yeah, you have to unmute yourself.
Okay, I think there we are.
There you are, yeah.
Thank you very much. Whilst we get tempted in treating numbers and forgetting that we are managing patients and human beings. What is very important, because when every patient comes through, our main aim is not only to relieve the burden of disease, but to educate the patient. So time allocation per patient is become very important. Our patients are not carriers, they are individuals and they are human beings. If you stretch yourself too much to an extent that you don't have enough time to take history and good history for you to manage a patient, what I always say, Dr. Pila, is to say, just like a carpenter, you measure 5 times and you cut once. The history becomes very important. So have time with each and every patient, take the history so that when you go into the management and the plan of management of a patient, you are confident that indeed you have done a good job and you'll be able to manage the patient.
Okay. Are you still with us? I see that. Oh. We lost a little bit there. I'm losing you.
We need to treat all of them with dignity. So when you treat dignity, it means you have to make sure that you've taken a comprehensive history. Once you go into your plan of management, you have done comprehensive work and you are able to manage the patient. So it's not mainly a game of numbers, but it's a game of how comprehensive you have managed each and every patient. And each and every patient, by the time they leave, they should be educated enough. So when you say it's a number of so many patients, it's not more of a numbers patient. So if the clinician is advanced enough to say in 20 minutes, I would have taken a history and I would have managed a patient, then you can count it from there. So it becomes a team effort of sitting and saying how many of these patients you can see. For instance, you would see that in certain circumstances, we do come up with these quotas and they are based on evidence on how the work can be done. So sit and have an evidence-based thinking and then come up with a plan to say, yes, at this time, this is how many patients you'd see. You'd rather book your patient and treat them with dignity than treat them like a bag of potatoes. Because once you do that, also you are running a risk of having complications. And that's something that we need to prevent at all costs.
Okay, I see that's Dr. Dejayang, who's got a hand. I'll come back to you. Let me just deal with there are quite a number of questions. I'll come back to you that have been asked. There's a question about, Mary says, I work with the gastroesophageal reflux disease patients, and dental erosion is a big problem that dentists and gastroenterologists do not pay attention to. I think you mentioned quite a number of diseases that we medical practitioners overlook. Can you comment on this one?
Yes, I think we need to, out of this conversation now, starting having to have conversations and not stop working in silos, especially if you are in institutions, work as teams. And if you are working, for instance, in like the section where the doctor is saying they are working, it's easy that you can invite a dentist over to come and see the patients. So we need to increase these conversations and also start having a conversation. There are mobile chairs that can be brought into a section where there is a lot of patients. So let's have the conversation. Let's look at the different conditions and let's see how we assist the patients working as teams.
Yeah, I think that's the same sentiment echoed by Thokozile, who says it's good to see universities collaborating and that we promote working together and breaking the silos across the different disciplines. And so that's a message that should be carrying from this talk this evening, that,
and
we work
Dr. Bila,
together.
not only in institutions, even in private sector, you could be sitting and working from your home and having your surgery at home, but we need to be able to start having the network. Now with spaces like this that you've created for us, we should be easily creating those networks where we can work together and you could be able to communicate with somebody. I mean, we are here now, we have seen management of patients, wherein you can have even an agreement and have the patient sign consent, wherein you're going to say, when you're sitting in my chair, I'm going to call an oral health practitioner, I am going to call a physician, let's take videos, let's be able to see these things, because you find that you might be working in a place that is very far. But now with technology, how do we utilize technology in making sure that we break the silos and we comprehensively work together?
Yeah. There's another question from Lynn Rosenberg. She wants to know, could school programs be a helpful way to assist with oral health education in children if this isn't happening already?
This is happening already. For instance, during the introduction, you've introduced me as one of the practitioners or a dentist from School of Oral Health Sciences, Sefako Makgatho Health Sciences. We do have these programs. So if you have a school that would like to identify, that you have identified that would like any institution to work with, just identify an institution closer to you. Let's be proactive also in that way to say, I am working in this area, I am close to UP or I am close to vets, approach vets to say, I'm an oral health practitioner working in this area, this is what I have identified. And of course, in us identifying, let's not leave out people living with disabilities, especially children. Let's not leave out old age homes. How do we work together? I have seen Dr. Bila, and I once again need to applaud the clinics team on some of the outreach work that we have done for our clients. And now we are saying also expand it to us also as oral health practitioners. We understand that our work comes at a very high price because now you need to have this chair. But we have seen that there's quite a change when now we have a mobile chair that can easily fit in somebody's boot. So let's see how we expand in making sure that we utilize the institutions that are there. At any given point in time, institutions are always looking for places where of pockets of people that they can work with. And also not only bigger institutions or tertiary institutions, there are clinics that are available that might be having mobile clinics that could be brought at any given point in time to specific areas to support the clinicians.
If I go to Olubumni, Azwindidi wants to says, in the absence of any dental pathology complaints, how often should one go for dental exam, and does age also become a factor? And I think this affects most of us here, I suppose. When should you see a dentist?
That's a good one. Thanks for that one, Dr. Billy. We are expecting that, of course, as you age, that things change a bit. But an adult, we're expecting them at least have come for dental care twice in a year. Whilst you can be brushing your teeth and flossing, there is a lot of food particles that go between the tooth and the gum or the bony area where the tooth is holding into place that you cannot necessarily clean with your own toothbrush. And this is what leads directly to what I've been referring to, which is periodontal diseases. So at least twice a year, we are calling on you to come to go and see your oral health practitioner. And as I said, you could start by just going to your oral hygienist and then graduate as accordingly. But twice a year, we are calling on our colleagues, please come and see us. We would really appreciate having this relationship that it is not just about patients, but it's about us also. And as I was preparing for this, Dr. Bila, for me not to be looking like I'm beating my fellow physicians or medics, also I've been reading a lot of research that everybody who is a health clinician, they wait until too long before they go and seek any form of medical assistance. But twice a year, oral health practitioner, and let's break this thing of self-medicating. Can we make the time to go and also support and have the conversation with our fellows in all the spaces that we need to be in?
I'm sure after tonight, there'll be lots of us queuing to see dentists across areas where we come from, including myself. I postponed my own examination about 3 weeks ago. We still have an appointment to go and see my dentist.
I'm gonna follow up on that one.
I'll give you a report. Olubumni, you can just unmute yourself and ask your question. Olu?
Yeah, good evening, colleagues. Yeah, good evening, colleagues, and good evening, the lovely presenter. It was a great eye-opening session. Some of the things you raised, ideally, if as colleagues, doctors, nurses, post-basic practitioners, if we have to do what we were taught in schools, we won't be having so much burden we are having. Because there's something we call systems review, whereby a patient might come with painful arm, but as a way of preventive medicine and holistic approach to care, you go to other systems. And oral system, oral cavity is one of them. But often we neglect that. So that is why we find ourselves where we are. Having said that, now back to the oral practitioners. I like the fact that you kept mentioning children, babies. When they come to you for whatever reason, do you do anthropometric assessment on them before you go straight to the oral problems they have? Because there's a lot of SEM, which we call severe acute malnutrition. And some of these patients, they do come to dentists, but are they picked up? So in summary, what I'm trying to say is as much as you are calling for holistic approach, which we fully agree to, do you also do that from your side? Thank you very much.
For the challenge, Doc.
Thank you very much. I specifically work in the maxillofacial and oral surgery department as a dental surgeon, not as a maxillofacial surgeon. And I specifically had given myself a responsibility of taking care of the children. At any given point in time, I refer children. So this is the reason why I'm saying this, because this is one of the practices that we make sure that it is done. Referral, referral, referral. As I was saying, you measure 5 times and you cut once. In that measurement, at any given point in time, when a child comes.
You muted yourself You muted yourself, Doc.
No, I
yes,
didn't.
Yeah, sure. Yeah.
Yes. So I was saying, at any given when you see a child with multiple caries, it's a sign of something else, Dr. Bila, and together with all the attendees. And so there, it's either a social problem and you need to refer that patient to a social worker. It's either a problem with the parents, so you refer accordingly. So yes, we do teach, because I'm part of a teaching institution, that we need to refer. Majority of the time, especially with children, that's why I kept on referring to children. There is always an underlying cause. So you need to refer for that underlying cause. But then, as I was saying, that it's easy for me to make these references because I'm part of a teaching institution. So it's easy for me to do referrals. How do we then, outside this, after we finish this conversation, start saying to all the other practitioners, especially in private practice, we need to now start forming this web of referral system. And if you are unable to send the patient, because also we are in a country where some of the patients that we are seeing might not have the resources. How do we use the latest technology, making sure that that patient is seen? And that today that the pediatrician would have talked to the patient and seen the patient, at least as a start, online, refer, get send the prescription to you, assist the patient to retrieve it. But how do we utilize the systems that we have in making sure that we're getting comprehensive holistic management of patients? So yes, as teaching institutions, because we are part of a complex, it's easy for us to do it. But how do we assist private sector?
Yeah,
to be able
I think the message has been transmitted quite clearly. The last question that we have for the evening, it's what is your advice on the effects of certain antibiotics on teeth? Okay, if I mute yourself.
I think I'm unmuted in this case.
No, I was talking to somebody else.
Oh, okay.
Somebody who's excited, they are saying. Okay, go ahead.
Of course, we do have an antibiotic that causes teeth to grow a brown stains. And this usually would not occur when the antibiotic is given to the child once they are given birth to. This would have occurred when the antibiotic was administered to the mother during the pregnancy stages. So that's very important. Again, measure 5 times and cut once. Take comprehensive history, because like, for instance, the clinician that was saying to us, I have to see so many patients. You would easily miss asking the patient whether, are you pregnant? And then you prescribe the antibiotic that could cause the staining of the teeth. And it's something that nobody will be able to forgive you for. It's legally and ethically incorrect because you did not take good history. And I am not lambasting the medics for having not, in this case, maybe it looks like because I was talking mainly to chronic medical conditions. We also do have clinicians that are oral health practitioner clinicians that don't take good histories, and this causes problems. So we need from all angles start saying, how do we work together and making sure that we don't create complications that could be prevented.
Okay, quite a mouthful. Thank you very much. We've rarely gone up to past, which means it was quite an interesting topic, and we got lots of questions that were asked and lots of information that we shared with us. It's quite been a wonderful evening that we've had of sharing information. But also what I might take away from you, I think, is collaboration across the disciplines, not only dentists and physicians, but also all other disciplines like allied health professionals, and that you should collaborate. And especially now also in primary healthcare, there is that need for collaboration. And I hear you speaking as a surgeon, saying that you measure 5 times and cut once. I think it's a nice phrase to catch up with, to embrace, and I'll always remember this. But I just want to thank you on behalf of Clinics Health Group for accepting my invitation and being part of this learning platform that we share with our colleagues every Thursday. And we know that it's not the last time that we hear from you. Sometime in the future, we'll invite you on other topics related to oral health. But also to thank all the colleagues who have stayed with us, quite a high number, more than 320, which is quite a high for us, in this last few weeks. And we just want to thank all the colleagues for joining us. And we know that you will be with us again next week. Please do join us. Next week we'll be talking forensic medicine. Please do join us. And I just want to thank Kamo also from the marketing team, who's been working so hard and every week, and making sure that we get the speakers and support and logistics for presentations and the slides. So just want to say thank you, everybody, and have a good evening. Sure. Thanks, Doc.